Hello, everyone, and welcome to this Advocate Chat as part of the Alamo Breast Cancer Foundation's Advocate Program, which is held in conjunction with the San Antonio Breast Cancer Symposium. My name is Michelle Tregear, and I am a 16-year breast cancer survivor, and I also serve as the Chief Programs Officer for the National Breast Cancer Coalition. Today, I am honored to be joined by Dr. Brooke Wilson, who is an accomplished medical oncologist and health services researcher. She serves as an assistant professor at Queen's University and a practicing medical oncologist at Kingston Health Sciences Center, where she specializes in the treatment of breast and gastrointestinal cancer. Her research focuses on health services modeling, resource stratified guidelines for cancer care, and secondary analyses and meta-analyses of clinical trial data to inform real-world oncology practice. She is also a founding member of the Common Sense Oncology Initiative, which also happens to be the focus of today's discussion. So Dr. Wilson, thank you so much for joining us.
So thank you so much. So my name's Brooke Wilson. I'm a medical oncologist at the Kingston Health Sciences Center up in Ontario, Canada, and I specialize in treating breast and gastrointestinal cancers, as Michelle has alluded to. I also have a master's in epidemiology, so I do a lot of work with real-world data sets, and I'm completing a PhD in modeling for health services research as well. I'm the breast cancer lead for my institution, and I also lead the breast cancer trials portfolio for the Cancer Center of Southeastern Ontario. As Michelle alluded to, I'm a founding member of the Common Sense Oncology movement, and I'm really pleased to be here today to tell you all a little bit more about what the movement is about.
Wonderful, wonderful. So jumping into Common Sense Oncology, how did you get involved and what really drew you to this initiative?
Yeah, so that's a great question. So Common Sense Oncology is now an international initiative, and we are lucky to have members from all over the world participating. But it really began here in Kingston back in about 2022. And around that time, I'd just come on as a new faculty here, and two of my colleagues, Dr. Christopher Booth and Dr. Bishal Gaiwali, had become, more and more vocal about some of the major challenges that we face in the field of oncology today with respect to choice of endpoints, substandard control arms, and of course, the rising cost of drugs in our field. And these issues really resonated with me. And it wasn't long before we were starting to plan the first annual meeting, which was held here in Kingston in April of 2023.
Okay. So I guess maybe you could tell us a little bit more about the impetus behind launching Common Sense Oncology. What was was there a particular moment or experience that sparked the idea?
Yeah, great question. So I probably can't speak to whether Dr. Booth and Dr. Gaiwali, who are really the brains behind the operation, had a particular spark or momentum that led to launching, but I can certainly comment on a few factors that I think helped me solidify in my mind the importance of the Common Sense Oncology movement. And they can sort of be summarized into two things. And one is the disconnection that we see between what patients think a drug might offer them and what the evidence actually shows it might offer. And then the second is what the true value of these treatments are for patients. So if we think about this first issue, which is the disconnection between what patients think a drug might do and what evidence shows it might do, we know that from trials, somewhere between 50 and 80% of people who are receiving chemotherapy with palliative intent for metastatic disease still hold some belief that that treatment might actually cure their cancer. And so that communication disconnection, I think, is really concerning and something that we as a field really need to work on to try and improve communication between patients and doctors. And communication and patient priorities is one of the major focuses of the Common Sense Oncology movement. So that aspect was really something that drew me to the mission and values of CSO. And then I think the second thing, I can remember a moment in my training when maybe a light bulb moment, as you would say, where we were discussing early on in my training, presenter was providing information on the evidence behind a drug that had become standard of care. And this was a drug that improved the progression-free survival for patients by about 3 months. It had substantial clinical toxicity. It had no overall survival benefit, and quality of life data was not really reported. And I remember this was very early, and I was thinking, well, if I was a patient, would I really want this drug? Like, that doesn't sound necessarily like something that's going to provide a lot of value. But looking around the room, there was a presenter who was very enthusiastic, and there were many audience members who were very enthusiastic. And I was quite junior at this time, and I thought, well, maybe I'm just a little bit out of left field, and maybe I'm not understanding something, and I kind of left it at that. But then not long after, I was in clinic discussing this available standard of care option with a patient, and they had the same reaction, and they thought, well, I don't want that. That doesn't sound like value for me. And it was really a moment that solidified that maybe it's more complicated, and maybe we need to consider these issues a little bit more. And that led me to really do some exploration and self-education on why clinical trials are designed the way they are, what the endpoints really mean to patients, and what patient priorities are within the context of a drug that may not offer survival but has potential added toxicity and cost for both individuals and health systems. So for me, that was a moment that really solidified the importance of these conversations and the work that Common Sense Oncology is now trying to move forward with.
Well, okay, so speaking of that, how would you describe the core mission of Common Sense Oncology in simple terms for advocates and the general public?
That's a great question. So I think at its core, Common Sense Oncology believes that we can provide better care for people living with cancer. And I think within that context, it's important to recognize that there have been considerable advances within our field in cancer research over the last few decades, and these have led to important new treatments that have meaningfully improved the lives of many patients. But on the flip side, there are also many new treatments that can be costly, come with uncertain effects regarding actual benefit for people living with cancer in terms of quality of life and the length of life. And then at the same time, there are also many people across the world who don't have access to some of the more meaningful drugs that we know have real benefit for patients. And that is something that I think we as a field need to work on as well. And so Common Sense Oncology is really a global movement. It's a network of oncologists, researchers, patients, and patient advocates, all with this common belief that we can do better in terms of patient care for patients. And that revolves around improving high quality access to care, compassionate care, innovative cancer care, and communication within our field. So we work collaboratively with others in the cancer research ecosystem, with patients and people with lived experience, all to put outcomes that matter most to patients at the center of research and care delivery.
Great. So, frankly, many patients assume that all approved cancer treatments are grounded in strong evidence and are going to deliver meaningful benefit. What concerns or gaps in current cancer research and care is CSO specifically trying to address?
So I think that's a really important and challenging question, because I think there are a number of aspects to this. But when we talk about meaningful benefit, I think it's important to maybe first recognize where we get the information to decide if something provides meaningful benefit. And that really comes down to the clinical trial. A lot of what we do in cancer centers around those clinical trial results. And so we have a large body of work in CSO that focuses on understanding those clinical trials and critically appraising those clinical trials to understand if that benefit truly is meaningful. And so I think what we're talking about in that sphere are some of the challenges that can threaten the value and the meaning of drugs within the constraints of what is demonstrated in a trial. And so that includes, what is the endpoint that was selected? Is it an endpoint that really matters to patients, such as overall survival, quality of life, or is it an endpoint with less certain value, such as progression-free survival? And then within the constraints of the trial, is crossover allowed? So crossover is a really important concept in a trial that can threaten the value and the meaning to patients. And to give you an example, if you have two drugs and you're trying out this new drug in the first line setting, but that drug has proven benefit in the second line setting, and we're trying to figure out if moving it forward is meaningful for patients, well, patients who don't get it in the first line setting should definitely get it in the second line setting if we have demonstrated benefit benefit for that drug. But
Mhm.
that doesn't happen in a lot of clinical trials. And so that can really muddy the waters, and it can make a drug look more beneficial in the first line setting than it might actually be when it gets rolled out into the real world. And so this is a real challenge. It's not adequately, I don't think, reported. It's not clearly laid out in clinical trial protocols sometimes. And I think we need to talk a bit more about that within our field. And closely related to that is the issue of post-protocol therapy, which may not be mandated within a trial, but involves what drugs and what treatments come after the patient has progressed within the study itself. And when many of our clinical trials are now being run on an international stage, sometimes the drugs available in some countries may be very different to what is available in North America, Europe, et cetera. And that also creates some challenges in terms of interpretation of the results and makes it hard to know if the results are truly meaningful for patients. And then finally, we have this other major issue that can threaten the meaningful value of a treatment, which is censoring and loss to follow-up. And we know that patients who leave a clinical trial because they're lost to follow-up or they drop out for other reasons, they tend to be patients who aren't doing as well as the patients who remain on the trial. And so that can also skew the results. And we have some challenges in the way we transparently report censoring for many clinical trials. And I think that's something that we as a clinical trial network, we need to work better on reporting these things. And so a lot of this work in the common sense oncology space is being conducted by one of our working groups, which focuses on randomized control trial appraisal and making some recommendations on how we can do these things a little bit better so that clinicians and patients can better understand the value that a treatment might offer them.
Right, absolutely. So, CSO emphasizes concepts like evidence, benefit, fairness. Can you really explain what that means in the context of cancer care and why they matter?
Yeah, so those are three very important concepts that are, somewhat connected, but also independently really important. I think the one related to evidence is perhaps the one we've alluded to the most so far. And we've talked about some of these issues related to the strength of the scientific evidence, the quality of the scientific evidence within the constraints of the clinical trial, and some of the challenges with respect to control arms and crossover and post-protocol therapy, as I've alluded to. And there are unfortunately many examples within our field where these issues have challenged the interpretation of our clinical trials. So I think improving the quality and the transparency of the evidence that we have is a really important objective that we should all work towards. In terms of benefit, I think when I think of benefit, I sort of conceptualize it in two ways. The first is what is the metric of benefit that the study is looking for? And we've sort of talked about that. Is it a metric that is really important to patients like survival or quality of life? Or is it a surrogate metric, something like response rate or progression-free survival, which has less certain benefit for individuals? So that's the metric of benefit. And then there's the question of the magnitude of that benefit. So some studies may detect a large magnitude of benefit, which is very meaningful for patients. Others may actually detect a very small magnitude of benefit, which might still be statistically significant, but may not be clinically meaningful for the patients in front of us. And in breast cancer, we are in somewhat of a privileged or unique situation where we enroll far more patients to most of our clinical trials than all other types or subtypes of cancer by many orders of magnitude. So we have a lot of power within our trials, which allows us to design clinical trials to detect relatively small magnitudes of benefit. And I think this is really important that we are able to communicate this clearly to patients, because sometimes a study that has a statistically significant result may not be clinically meaningful for individuals. So that's the challenge with respect to benefit. And then I guess the last concept, which is perhaps a little bit more separate, is the one that you raise about fairness. And I think there's lots of aspects to fairness that we can think about, but I also think of fairness as things like equity. And common sense oncology is a global movement. So we're very interested in global equity and access to medications that can meaningfully improve the lives of patients regardless of where they live in the world. So I think we also need to think about fairness and equity, not only from a global context, but even within our own borders. So I know here in Canada, where I practice, we have some challenges with equity in terms of access to treatments for patients who live in rural versus urban environments. And we also have issues of equity between our provinces, because because our health system is governed at a provincial level. So someone who lives in one part of Canada may not have access to the same drugs that someone has in a different part of our country. So those are issues of fairness and access and equity that are really important. And I'm sure there's similar issues that are reflected in the United States and in every other country across the world that I think we all need to work to improve.
So, why do you think the oncology field has drifted away from treatments that offer clear, meaningful benefit to patients? Is it a systemic issue, a regulatory one, or something else?
So I think that's a great question, and I think the answers are probably pretty complicated, but in my mind, I try and break it down into three big things. I think there are some historical factors that have contributed, some practical reasons, and then some profit-driven reasons as well. So what we're really talking about is why has there been this rise in surrogate endpoints as valid approvals for cancer drugs? And so if we think about what PFS is and when it was initially designed, it was designed to try and help investigators select drugs that showed promise in early phase clinical trials, so phase 1 and 2 trials, to select the ones that look promising to move into a phase 3 clinical trial. But it was never conceptualized as an endpoint for regulatory approval in a phase 3 study design.
Mhm.
But this idea that we could have a surrogate endpoint that led to an outcome from a clinical trial earlier is obviously appealing. And then if we layer in what was happening around the same time in the United States, we had the epidemic of HIV and this importance of speeding the time to drug approval for individuals with HIV, creating this real pressure on the healthcare system to try and increase the speed of drug approval. And when that was done for HIV and drugs started to come through that pipeline quicker, a similar precedent had been set for other spheres of medicine, including cancer. So we started in '92 to have the US FDA begin accepting PFS as a valid surrogate endpoint for phase 3 clinical trials. And this really created the regulatory environment for surrogate endpoints to eventually become the dominant endpoint in oncology that they are today. And so then next we can consider some of the more practical reasons. And I think this really centers around that time. So PFS can be measured more quickly than overall survival. And then that can shorten the follow-up time for clinical trials, which has logistical and financial advantages. But in reality, if we look at clinical trial across clinical trials, the time to get a PFS endpoint is only about 11 months or a year faster than waiting for an overall survival endpoint. However, we need to acknowledge that that can vary significantly. So for things like breast cancer, which have a long natural history, it's actually going to be many, many years before a survival endpoint reads out compared to a PFS endpoint in most circumstances. So that can create some additional challenges in terms of time to approval. And there's always this pressure that we want to get drugs to patients faster. But I think it's also really interesting to look at a recent study that was published out of the UK that actually asked patients, how do they value certainty of overall survival versus speed of approval? And firstly, they found that patients didn't actually place a lot of intrinsic value on progression-free survival, and that they were willing to wait up to 2 years longer if the additional time found that there was certainty in terms of the overall survival outcome. So I think that's really important for us as clinicians, but also for the regulators to consider. If that's what patients want, then we need to really consider whether this rapid approval process is in the best interest of patients, and if it's aligned with their views and preferences. And then finally, there are these financial incentives. So we know that industry conducts more than 90% of the phase 3 clinical trials in oncology today. And so for them, being able to demonstrate a benefit earlier through a surrogate endpoint allows them to take their drug to market more quickly and begin to make profits at a shorter timeline. So not all studies eventually go on to show a survival or a quality of life benefit either. So for industry, the chance of a positive outcome if there's a PFS endpoint that's met, rather than waiting for an overall survival endpoint, can also be advantageous. So I think many factors have played into this environment that we now live and work in.
Right, right. So I want to, CSO embraces advocates, involves patients and advocates in shaping its vision and work. Why do you think that's so important? How is CSO actually doing that?
Yeah, so I think that's a really great question. And So who is CSO? We're really a group of people who share a common vision and a common goal, which is for the delivery of compassionate cancer care that prioritizes things that matter most to people living with cancer. And so while the vast majority of our members are physicians, we do have patients and patient advocates who have been involved in Common Sense Oncology right from the beginning. And I think this is one of the wonderful things about this group. And so they have and will continue to play an essential role in shaping our mission, our vision, and our work streams. And to speak of work streams, we have a number of work streams involved in clinical trial design, health policy, and education, but we also have an entire work stream devoted to patient priorities, which is actually led by Michelle Tregear on the other end of this call. So I think this is a really fantastic aspect of this group. And I think that having patients involved right from the beginning is essential to ensuring that the work that we're doing is really aligned with what matters most to individuals with cancer.
Right, right. So I want to shift a little bit to talking a little bit about some of the tangible outcomes and projects that CSO is working on. Can you talk a little bit about some of those projects and what this initiative has accomplished to date?
Absolutely. So we're a group that's in their infancy. So we've only been working for a couple of years now, but I think we've actually made a number of important contributions despite that timeline being relatively short. So the first one would be the publication of our CSO mission and vision in Lancet Oncology, which I think plays a really important role in bringing awareness to some of these issues to the broader oncology community. We've also published a checklist, which provides some structure for patients and clinicians as they analyze and critically appraise clinical trial publications, and also helps to raise awareness about some of these important issues in clinical trial design that require careful thought and consideration. We've been doing a number of speaking and listening tours, some directed to patients, but also some directed to physicians. And these have been really important to help make sure that our work streams and our projects are actually well aligned with the broader oncology community as a whole. And then a lot of our focus has been also on education. So education in the form of journal clubs. We've had symposia at many international meetings to raise awareness and educate physicians and patient advocates about our work and these issues. And we also have a successful fellowship program where we're bringing in individuals from all over the world to provide mentorship and training on some of these challenges in our field and to develop projects with them to help move forward and create solutions. And then finally, we have a piece of work that I think is really exciting and important that was led by yourself, which is the patient charter. And this is a really important document that helps to outline what patients should reasonably expect from any clinical trial. And it's especially important because it was co-created and led by patient advocates.
Right. Well, thank you. So I guess, what do you hope the oncology landscape looks like in 5 to 10 years if CSO principles are adopted more widely?
Yeah, so that's a great question, and I think there's many things that we could focus on. But I think, in a nutshell, I would consider 4 things to be really important. The first is better communication strategies for patients and physicians, so that patients are making truly informed decisions about the care that they're choosing. The second is a clearer understanding of what drugs actually lead to survival and quality of life benefit versus radiographic stability alone. The third is I would love to see more clinical trials designed to detect health-related quality of life as a primary or co-primary endpoint in phase 3 clinical trials, and to make sure that that data is reported in the primary publications and is as important as the survival data that is presented. And then finally, I think I'd like to see some more transparency in the way clinical trials are reported through these key elements that we've been discussing and that we're advocating for, which include things like crossover, censoring, and post-protocol therapy.
Right. Right. Well, hopefully we actually see changes in those things, I think is what I'm hoping for. So what gives you hope that meaningful change in oncology is actually possible?
Yeah, so I think it's actually the momentum with which CSO has gained traction, which really speaks to the fact that many people in our community, including patients as well as clinicians and researchers, identify with these challenges and issues. And that's really the first step to meaningful change. If we don't have a body of people behind us that support this movement and this work, then it's going to be harder to get change. So the speed with which people have identified with this work is very encouraging. And it really has struck a chord with physicians and patients alike. We receive here at in Kingston emails on a daily basis from patients saying how much they appreciate the research that we're doing and how they are really excited to hear this sort of alternative viewpoint, or this viewpoint that maybe isn't discussed as openly in mainstream oncology. And that really gives us the hope and the validation that we're doing something that actually matters to patients. So I think it's that engagement that we're seeing from the community upwards that really gives me hope for meaningful change.
Right. Well, I'm going to ask you one last question in closing, and that is, because this is an initiative that engages advocates and patients, how can they get involved to support the work of Common Sense Oncology?
Yeah, that's a great question. So I think there's a few easy things that can be done. So firstly, I would encourage anybody who's interested to sign up to our mailing list. We give you updates on ongoing work on a regular basis, so you can keep up to date on what we've been working on. We also have been hosting these educational seminars, our major meetings such as ASCO and ESMO, and we're doing one at Aortic this year in Africa as well. So if you're attending those meetings, please come along and learn more about our work. It gives you an opportunity to also discuss with us on a more informal basis about any questions that you might have and pathways for engagement. And then tell your friends and colleagues about us. We're a movement that's growing from the ground up. So spread the word if it's something that you think would be helpful or useful for a colleague or a friend to learn about. We'd love to speak with them as well. And then really we're trying to shift a mindset and to raise awareness about these important issues. So I think it's really important to discuss them openly.
Well, I just want to thank you very much, Dr. Wilson, for taking time to educate our patient advocates about all of these issues and about the Common Sense Oncology Initiative. And I also want to thank the Alamo Breast Cancer Foundation for this wonderful opportunity to share information about Common Sense Oncology. So thank you very much.
Thank you so much. It's been a pleasure speaking with you, and I'm really grateful for the opportunity.